After this brief introduction about the importance of the diagnostic test accuracy studies in our daily practice, let me give you some information about the technical versus clinical precision, namely these sensitivity, specificity, etc., these indicators. I would like to convey this information by on behalf of an example case scenario. There is a fictitious case here. One baby, newborn, was screened for muscular dystrophy using this test, this creatinine phosphokinase test. And unfortunately, it returned positive. So the next thing we have to do after having this kind of serious test positive is, of course, what should we do? What kind of message should we give to the parents, to the relatives of the baby? Should we tell them that this baby has muscular dystrophy? What is the probability of that baby having this condition? And we have to look, of course, at the test, how well this test functions, how well it differentiates between the sick and healthy babies. For that, we can look at the sensitivity and specificity, which we call the technical precisions of the test. And as you see, these are pretty high, 100% sensitive and almost 100% specific. This is a very good test, and we have not so many of this kind of good tests actually in our daily clinical practice. However, there is one important point here. This is the prevalence of the disease. The prevalence of muscular dystrophy in the community is very low, unfortunately. 1 out of 5,000 newborns, that means 0.02%. So after having this extra information about the prevalence, should we consider to change our opinion whether the baby has muscular dystrophy or not? This is the question. To answer this, I should show you in more detail what positive predictive value and negative predictive value mean. Here I have a population scenario of 10,000 people, and administering this CPK test, what would we have? What kind of results we would have? Since the prevalence is 0.02 out of 10,000 people is 0.02. Sorry, is 2 people. That means in the population, the prevalence, this is the red box here or above, in the population, we have only 2, we expect to have only 2 people with the disease. The remaining people, the remaining 9,989 are healthy. So, and this is how we calculate sensitivity. Sensitivity is calculated by, is defined as the ability of the test showing the sick people, these 2, that means 2 divided by 2 plus 0. This is 100%. 100%. And specificity, on the other hand, is defined as the ability of the test showing the healthy people returning negative, showing negative among the healthy people. And there, since 2 people out of these 10,000 are sick, the remaining are healthy. So the but our test has a specificity of 99.98%. That means there will be out of these healthy people, 2 will be categorized as test positive, although they are healthy. So the specificity in this case would be 9,996 divided by 9,996 plus 2. On the other hand, positive predictive value of the test is the probability of a test returning positive in a group of people from which we don't know whether they are healthy or sick. So this is, in our case here, this is 2 plus 2, 4, and 2 divided by 4, that is 50%. 50%. And negative predictive value, on the other hand, is the ability of the test returning negative in the similar group of people. So while we call this sensitivity and specificity the technical precision, the PPV, positive predictive value and negative predictive value, are called as the clinical precision. They are more relevant to our clinical context, because in one context, the prevalence of the disease might be high, and then if you have a higher number here above, that means your positive predictive value will be higher. So the value of the test in this case will change according to the prevalence of the condition. And that's one important reason why family doctors, for example, who work in a low prevalence condition, use less diagnostic tests compared to specialists who work in hospitals where they have more increased prevalence of the diseases, of the different conditions. So what now? What should we conclude? The conclusion, of course, as you see from the previous slide, I've seen from the previous slide, is out of these patients, only 0.02 are expected to have the condition. So if we would have 100,000 people, they would be 20 sick patients. And while the test is able to differentiate, because it is 100% sensitive, while it is able to differentiate all sick people, it is not able that good. It is not that good to differentiate the healthy people. Among the healthy people, it will categorize 20 as sick. So it will recognize all the sick people, the 20 real sick, real disease, whereas it will have categorize 20 healthy people as deceased. That means this is false positive. This is false positive, whereas this one is true positive. So therefore, the positive, since the positive predictive value is 50%, we should tell the family we are not sure about, we cannot conclude, and we are not able to tell with a high percentage that this baby has the disease, but the probability is 50%. Here, once more, the same figures showing the sensitivity, specificity, positive predictive value, and negative predictive value. Okay, let me stop here.